you are recording?
Yes, I believe that's a recording.
Yes, it started. Go ahead,
Yes.
Mahmoud.
Okay. Okay, so we're gonna start with today with DETFA. DETFA it's a provincial specifically in Ontario. DETFA means it's a Drug Interchangeability and Dispensing Fees Act. So what does it mean exactly? So if you're gonna fill a prescription, okay, the most important part, there are two things you have to mention, is to show that you're dispensing fees, and this should be obvious to the public once anybody like comes into the pharmacy. So it has to be obvious. Okay. And number two, it's mandatory to dispense the generic brand. Okay, not the brand name, to save the taxpayers' money. That's what's called DETFA. Okay. I believe if you open ODB formulary, it's every molecule has its own generic, and generic means it's actually indicated by Health Canada. If you're gonna like get a prescription from a doctor says it's Leptor 10 milligrams, you have to dispense the atorvastatin. Okay. Atorvastatin, either like whatever you have in stock, like atorvastatin, let's say APO or Teva or Oro, doesn't matter exactly what it is. Okay. However,
ده في اونتاريو بس دكتور، ده في اونتاريو بس.
sorry.
Okay, you are right here. It is in Ontario.
Because everyone has like every province, Armenia has his own formulary. You know what I mean? So that's why I said it's a provincial. So whoever decide the formulary interchangeable medication, it's per province. Let's say, for example, we can say here in like the interchangeable for Lipitor is APO atorvastatin, which is covered. Maybe in Quebec, maybe it's another like Teva or Oro. So it depends. Okay, as per price, and we know the generic price is indicated by the province, right?
But it is not mandatory to dispense the brand or the generic. I can interchangeable.
Okay, so that's another scenario here. So when are the exceptions to say, okay, at this point only I'm gonna dispense like the brand? In two scenarios. One of them, if the doctor said no sub on the prescription, so at this point you have to dispense the brand name. This number one. Okay. Or if the patient asks you specifically, okay, listen, I want to have my brand name, at this point you can dispense it, but you're gonna charge him the difference. Okay. And for example, if you got a prescription that says please dispense APO atorvastatin, and you don't have APO in stock and you have Teva, it's your right to change it to Teva. It's fine, as long as the patient is okay with it. Okay, so the patient here is the key player. The patient is the only one who has the right to ask for his own generic. Got it? Okay, Armaya?
Okay, sir. Thank you.
Okay. If you open the ODB formulary, and it's like kind of a homework, if you want to go through it, you will find the difference. I believe last time we checked the difference in prices between the brand and generic stuff. Okay, so this is a law actually. DETFA is one of the acts or one of the laws that we control like our practice here in Canada.
معلش يا دكتور، هو البيشنت يعني لو قال انا عايز البراند بنصرف له، بس بنحاسبه على الديفرنس، صح؟
Definitely, exactly. So because the government actually pays only for generic, so the difference in price has to be paid from the patient pocket.
بعد إذنك كنت عاوز أسأل سؤال، هو الفورمولاري أكتر مش هو related للهوسبيتالز، ولا هو الفورمولاري أصلا بيتطبق؟
Guys, please let's keep the discussion in English because we have here our friend.
Okay. My question is, does the formulary is related to the hospitals or community pharmacy?
Okay, so that's a good question. Actually, there is a formulary specifically for hospitals. What this formulary means? For example, if you got a prescription from a hospital pharmacy to a hospital, from a hospital doctor to a hospital pharmacy, okay, and says, for example, lansoprazole 30 milligram once daily. The formulary in the hospital says, okay, for PPIs, we only dispense here pantoprazole. So you have the capability, if you're working in a hospital pharmacy, you have to set the capability to switch any PPI as per the formulary you have in the hospital. This is number one. The formulary in the community pharmacy is regarding the reimbursement of the government or of the province. Let's say, for example, the government will pay atorvastatin APO 10 milligrams. Okay, so if you get a prescription with Lipitor, here you cannot switch to rosuvastatin. Here you have to dispense Lipitor, which is atorvastatin, APO, Teva, whatever interchangeable they cover. You got the difference between them, Ramon?
Oh, yes. Yes.
Yeah. Okay.
Yes.
So
Doctor,
yes,
doctor,
yes.
please, I don't understand something. So we have two formulary, one from the hospital and one for the province.
Every hospital, yes, every hospital has its own formulary, and as a pharmacist in a hospital, you have the capability to switch, doing switching. In the community pharmacy in Ontario, you cannot switch. However, in some provinces like Alberta or something, you have the capability to switch under certain circumstances. Okay.
Each hospital, it is not the formulary for all the hospitals. It's each hospital.
Yes, some hospital. Yes, you know why? Because the PTD committee in each hospital has their own tender, has their own, whatever, So as per, because they got the budget, they have a specific budget, Armenia. Okay, so they have to allocate it as per their own needs. Let's say, for example, you got a very nice price for rapebrazole, for example, 10 milligrams. So they will switch automatically as per their budget, right? So if you got, like, let's say pantoprazole, lansoprazole, okay, any PPI, they will definitely stick to the formulary that they have in the hospital.
Okay, now all the persons in this hospital, if they take in PPI, he will take one in the formulary of the hospital. I am right?
Exactly, you are right.
Okay.
Right.
Okay, but in the community pharmacy,
It's different. Community pharmacy is different. The community pharmacy, you're gonna stick to the formulary that we have, like the ODB formulary if you're working in Ontario, or we don't have this capability here in Ontario as a pharmacist in the community pharmacy. However, if you're working in another province, that's why I said it's a provincial. However, if you work, let's say, for example, in Quebec or in Alberta, you as a pharmacist have this expanded scope.
Okay. For example, a doctor write a brand name for whatever the drug. I don't know whatever. And I have in the formulary in the province another brand name, and the doctor don't write not strict to the brand name. So I can change to one which is covered by the province. I am right?
Okay, so if again, so you have a brand name as a prescription, let's say Lipitor, and Lipitor here is not found in our on back order, for example, right? And then you have in the stock, and you have in stock the Prespor, right?
It is not my question. The doctor light Lipitor, and it is not covered by the province, but the one is covered is Apolipitor, for example. Okay.
Yes, definitely. You have to dispense the atorvastatin. Yes.
Because it is covered by the province.
Yes. Yes. That is the root of the thing.
Some patients refuses to get the generics. Okay, in this case, he has to pay for the Yes.
Yes. Yes. Okay.
Okay. So Armia, let's have a question about the point you just raised a few seconds ago. It's about if your patient is admitted to the hospital, and the physician prescribed to him a PPI like omeprazole, while in the hospital formulary, it's only pantoprazole can be dispensed, and the patient refuses to get the pantoprazole. He wants to get the omeprazole. Okay. what you can do here in this situation. You have only on the hospital the pantoprazole and only omeprazole. The patient want to take the prescribed one, the omeprazole. What you can do?
Again, sorry, because my connection is lost. Again, please, again, can the question, because I
So
don't.
as you said, you mentioned the point here that if the patient, like for example, admitted to the hospital, okay,
Okay.
and the treating physician give him a prescription with pantoprazole, okay, 40 milligrams, for example.
Okay.
Okay, and in the hospital formulary, only omeprazole is enlisted in the formulary, and the pharmacist try to dispense him the omeprazole as per the formulary he has, but the
Yes.
patient refused because it's not the same medication the
Okay.
physician prescribed.
Okay.
دكتور هو في ايكو او حد فتح
ما
unmute؟
أنا
I think so,
okay.
yes. I think we have there's like noise in the background.
Yes, something unmuted.
Okay. So again, now the questions, the doctor write the pantoprazole, and in the formulary of the hospital is omeprazole, and when
Yes.
the patient see it is an omeprazole, say no, I need what the doctor written. It's correct.
Correct.
Okay, what can I do from my knowledge? I haven't an
Very easy
experience
one.
about that, but
Mhm.
from my knowledge, if the patient need to take what the doctor written and he refused anything else after an explanation, it is the same drug and blah blah blah. Okay, we have to respect the patient autonomy and get it from outside the hospital and the patient will pay about this. From my knowledge, I haven't. Maybe I am wrong.
Okay, so you will refer the patient to community pharmacy.
Yes, we refer it to respect his autonomy. After an explanation, it is the same drug and it
Okay.
is the same bioavailability by a language that the patient understand me.
Okay. Okay, that's it. So I think yes, it's just I want to make sure that you get the point. But yes, your answer is correct. You can get it from any community pharmacy.
Yes.
Okay. Okay, guys. So again, this is the main issue of here of the what's called like the DEDFA or the drug interchangeability and dispensing fee.
The hospital get from the community pharmacy, or the patient will get the drug from a community pharmacy?
The patient.
Patient.
Yes, the patient.
According to his insurance, if it's but it's the patient's responsibility.
Oh, okay.
Sorry, one question here. If there is any specific cases where we have to stick to the brand name that the patient come to the hospital with, like in some cancer patient or psychiatric patient?
Okay, again, so if you are an inpatient hospital, okay, inpatient, like you're admitted and you're still inpatient under the care of the hospital inside the hospital, you're gonna stick to the formulary of the hospital, okay? So it doesn't matter like brand, generic, it doesn't matter. You're gonna stick to the formulary as long as you're inpatient. If you're outpatient, it's totally up to you. So if you're going to the let's say for example, community pharmacy, okay, and you want like Seroquel, not the quetiapine, the real Seroquel, the brand one, so it's okay, you pay from your pocket the difference, no one will tell you no. Okay,
Yeah,
got it, Emmy?
yeah, thank you.
Okay, so it depends if you are in an inpatient or an outpatient. Okay, so that's and how you can explain to the patient the meaning of interchangeable. Okay, so you will say who said actually or who decide those molecules are interchangeable. It's Health Canada job, not our job. Okay, so when they say atorvastatin 10 milligram is interchangeable to Lipitor 10 milligram, so that's their job, and we stick to it. So Health Canada decide which is interchangeable. So we have to communicate this message to the patient. We have to tell them, okay, so interchangeable means they have the same efficacy, almost like this, or like 99% or whatever, like, pharmacokinetics are almost the same, stuff like that. So no big changes, just different companies, manufacturing companies. Okay. So same amount of like active ingredients. So that means like 10 milligrams exactly should be equal to 10 milligrams Lipitor and atorvastatin. Okay. Comparable pharmacokinetics, administers the same way as a drug prescribed. You cannot say, for example, dexamethasone 5 milligram tablet is interchangeable to needles or vials. They're not interchangeable, so it has to be exactly the same, almost like the same dosage form as well. Okay. So that's what's called by drug interchangeability. What about biologics? Let's say, for example, if you got like a Remicade, for example, and after Remicade, like patency gone, after let's say 5 or 10 years, so what's going to happen? Another company can come up with like a biosimilar here. It's called biosimilar. Biosimilar version of biosimilar drug. Biosimilarity is different from interchangeability. So, for example, let's have this as a comparison here. So, when I say atorvastatin is interchangeable to Lipitor, that means both are okay to be used for LDLs medication. Okay. If I say Remicade is biosimilar to X molecule, that doesn't mean the same thing. To X molecule to be biosimilar, and it wants to be indicated in the same medical condition, it has to go through other studies to prove that this biosimilar drug can be indicated for the same indication. Is it clear at this point?
Sir, please, I don't understand. I have a problem mainly with the meaning of biosimilar from the evaluation. I don't understand what is the biosimilar.
Okay. Biosimilar is, we can say, same thing as interchangeable. Let's say, for example, biosimilar is this term is said on any monoclonal antibody. Let's say Remicade. Remicade is a brand name monoclonal antibody, right? If you want to, if after patency is gone, another company come up with the same, or like we call it biosimilar monoclonal antibody, and they claim that this medication is exactly the same thing like Remicade. Okay, so this, when they claim something like this, so that doesn't mean here, that doesn't mean that it's going to be used as the same indications. Remicade can be used for Crohn's, can be used for so many autoimmune disease. Another company came up with a biosimilar molecule. That doesn't mean Health Canada will approve it right away with the same indications. And however, this is not the case in the interchangeability. Interchangeability, once it came up with an interchangeable or generic drug, definitely 100% is going to be used as the same indication. Biosimilar, it comes with antibodies or like monoclonal antibodies. So for either carcinogenic medication or autoimmune disease medication, having the word or having the title biosimilar doesn't mean that Health Canada will approve all the other indications of the brand name. To approve these indications, you have to go through extra studies. Is that clear, Armia?
Yes, now I am understand something. It is the biosimilar. It is not like the interchangeable, the interchangeable drug like Lipitor and Lipitor. It is approved right away by the Health Canada because they know that they are bioequivalent. But now for the biosimilar, it is the same drug as you mentioned, that is monoclonal antibody. It is like the other drug, but from another company. So we need more studies. We need more bioequivalent because I think that is because the technique in the manufacture or
it's different. It's
different.
Exactly.
I am right?
Yes, correct. Because it's the same. The main point here is the biosimilars or biological drugs are following like a very sophisticated and complicated manufacturing processes. Okay, it's not like the oral or the other thing like the generic medications. So that's here. There is a huge chance that could be several discrepancies between the molecular sizes or the manufacturing technique between one company and another. So here you have
Yes.
to, even if you make, if you manufactured already the same product, you have to approve its efficacy in a clinical trial.
Okay. It is called biosimilar because their action inside the body, it is the same.
Exactly, but they are not identical like interchangeables. So they are comparable, but not identical. That's why
Yes.
Health Canada cannot approve the same indication.
Okay. Thank you.
Okay?
Thank you.
So I believe those questions will figure it out what's happening exactly, and I'll clear out the debate here. Tamam? Yes. So that's what. Okay. So that's what is the difference between interchangeability, substitution, and switching? Okay. So again, so interchangeability, to make this clear, interchangeability, if you got a prescription with like Lipitor, we have atorvastatin, same strength, that's interchangeable. Feel free to dispense the generic. Okay. Switch substitution, let's say for example, an substitution or switching, this can happen either in another province other than like actually Ontario, or in the hospitals. For example, if you got a prescription with ezetimibe, let's say ezetimibe, okay, and they don't approve ezetimibe in one of the formularies in this hospital, so they give atorvastatin. So that's switching. We switch to the other molecule, to another molecule, another brand, sorry, another group. Okay, so we switch completely. Substitution, when the same molecule in the same group, let's say atorvastatin and you have rosuvastatin, so we give rosuvastatin only for this medical condition. So that's clear. So that's the difference between interchangeability, switching, and substitution. Okay, so we have a question here, doctor, when we need biosimilar and market. What do you mean by when we need? The patency of one of the brand names is gone, so other generics to make the prices like a little bit lower or affordable, so they come up with biosimilar. So it's a price wise mainly. Is the difference between the interchangeability, substitution, switching is clear?
Sir, can you give me the definition again from second for the biosimilar drug?
Biosimilarity?
Yes, you have here. You write it in. Yes.
Yes. What is biosimilar? It's here. Man. Biosimilar is a new, highly similar version of biologic drug that comes to the Canadian market by different manufacturer after the patency has expired. Tamam? Biosimilar, previously called subsequent entry biologics. So if you have that's mainly biologics, or even like monoclonal antibodies, or like any kind of this new technology or new medications that comes up. If after the patency gone, okay, some other players in the market wanna take part of the cake, so they do that and try to have as much studies as they can to include or conclude themselves in the formulary. So here is going to be a win-win situation between the new manufacturer and the hospitals to decrease the prices or the expenses. Okay, so that's pretty much the main reason why biosimilarity is needed. Okay, however, Health Canada is strict about it because they're not identical. So we have to go through further studies to make sure that, okay, this biosimilar molecule, new molecule, is exactly the same and can be indicated without no other side effects can happen for the same medical condition. Okay, Armand? So they're not identical, but they're comparable.
Yes.
Okay?
Okay, thank you very much.
Okay. And let me go through this. I cannot understand what you wrote, Rimon, please. So if you don't mind, just speak up.
I want to illustrate that biosimilars is related more to insulins, monoclonal antibodies. This difference is due to the difference in sequence of amino acid between the generic and the brand because of the know-how of the brand. So it may, for example, there are similarity almost 70 to 80% between the two molecules, but at the same time, the difference in this sequence will result in difference in the efficacy or the results. For example, when we have a brand for Mixtard and it's a generic, so we can call them as biosimilars.
Yeah.
Yes,
Yeah.
let's have an example of the current two vaccines of Moderna and Pfizer, for example. They have
Exactly.
been manufactured in the same manner. It's the same RNA approach, but you cannot anticipate the side effect of this one from the Pfizer vaccine to the other vaccines. Also, the effectiveness. Yes, it's here the effectiveness almost the same, like 80 and 94 to 95%, but also you cannot depend to approve, like Health Canada to approve Pfizer vaccine cannot rely on the result trials of the Moderna vaccine. Okay, they have to study post studies like these trials and these trials. Like for generics medication to approve like any other generic, if you've manufactured atorvastatin in your own in your own manufacturer, what you have to do, you have only to do that the product contains atorvastatin. What each tablet contains, for example, 40 milligrams atorvastatin, and you don't need to provide any new clinical trials on atorvastatins, for example. You got what I mean? The situation is totally different from biologicals to the normal or regular medications, which are the generics. Is it clear or?
Is it clear, Shabab?
Okay. Yes. Okay. Good.
Yes, clear. Okay, عرفت did you know when only like the no sub issue? Do you know what's the meaning of no sub? Okay, let's say if you got a prescription with it's written on it like no sub, that means no substitution. So what happens in this situation? You have by law you have to dispense it as it is. Okay. So the situation of no sub, just to let you know, okay, if a patient tried two generics and he didn't get the full efficacy, or for example experienced any kind of allergy or side effect that is not tolerable, so the doctor role here is to fill that form, send it. It's his job, not our job, and then he will write a prescription says no sub. But so once we get a prescription says no sub, so we assume that happened. So at this point, we're going to dispense the brand. Okay? Is that clear? I will assume that's clear.
Yes,
inshallah clear. قدم المشيئة بس.
Yeah, okay. The role of the regulatory colleges, like for example, like Alberta College of Pharmacists and Ontario College of Pharmacists. Okay, the main regulatory role, because there is usually like a very confusing questions come here. Says, okay, who regulate the profession? NAPRA, and people like either be confused between either NAPRA or the colleges. So to cut it short, is the colleges who regulate are the bodies that are authorized to regulate the profession, not the NAPRA. Okay, NAPRA is like a complementary association, but they are not controlling or not regulating the profession. The colleges are the regulating bodies. Okay.
Doctor, question please.
Sorry?
Question please.
Yes, question, yeah, shoot it.
Then this, like in this point, they're playing with words, and they usually ask about the pharmacies. Who is like regulating the pharmacies?
Yes, the college.
The college too?
Yes, yes. The college is a regulatory body for either the pharmacists and the pharmacists.
Okay, and is there any difference if we have to look to the words like standards or guidelines, or both of them may like regulate the
Okay.
guidelines?
Let me give you like when I started to open my pharmacy, so I have to see what are the regulations valid, right? So this regulation is clearly mentioned in the website of the college, not the website of the NAPRA. So that's number one. And then when you open your pharmacy, you have a what's called first audit or opening audit. This happened again by the college. Okay, so they send you like a pharmacist from the college, and they check every single thing as per the application or as per the guidelines they put on their website. So that's number one. And then they give the approval or not approval. That's number one. And the same day, okay, let's say if they give approval, so they ask who's going to be the manager, and then they do assessment for the manager as well on the same day. Okay, so both, they do both, not the NAPRA. The college do both. Okay.
Okay, so what's NAPRA rules?
NAPRA, exactly. So NAPRA is responsible for scheduling. That's number one. And work in parallel with the college as well, to help the practice moving. But if you did a dispensing error, the college will, we can say, I don't want to say like punish you, but they will be concerned, not the NAPRA people. Okay.
NAPRA is like advisory board only. It gives like it work in collaboration with other.
In collaboration, but
college.
whoever regulates, exactly, whoever regulates a pharmacy and the pharmacist is the college. Our profession is self-regulated. What does it mean? The college is a group of pharmacists, like our peers or our colleagues, and they are actually obligated to do their 600 hours per year to keep their license. Okay, so our profession is self-regulated.
Okay, so last question. Who oversees or supervise the workflow in pharmacies in Canada?
Sorry, buddy. Sorry, I didn't hear you. Sorry.
Who oversees or supervise the workflow in pharmacies in Canada?
The workflow.
Who supervise the working people?
You mean like errors, the errors and the responsibility, the accountability of the pharmacist? You mean?
No, like question is like that. Who supervise the workflow in pharmacies in Canada?
The prevention colleges.
What do you mean by workflow? What is the workflow?
If I know, I will answer the question.
The many of the.
I think he means the workflow inside the pharmacy. No, the prescription, the dispensing. Yeah. I think it's the pharmacy manager, right?
They're asking about like college or not.
Yes, look, for the workflow, yes, what the role of the technicians and etc. Yes, the pharmacy manager could do that, but you have some restrictions in the pharmacy, like for the cytotoxic drugs. You have to keep the cytotoxic drugs away from the other medications. So it's yes, it's the manager's role, but it has to be in compliance to the provincial regulations as well. So what I understood from the workflow, it means like the work sharing or the organization of the process. No, it's not the scope of practice, because technician will be always technician. He cannot do the pharmacist role. It's like the organizing the process. If it's all
okay,
about
so
organizing.
sorry, Muhammad, for disrupting you. Okay, so that's you raised up a good question. Okay, Fayed, the job description is it's mandatory. You have to go through the college. Everyone has his own what's the difference between the assistant and the technician and the student intern. That's by the college. That's number one.
Yes.
What about the workflow? The workflow is up to the pharmacist who's leading the shift. Workflow means the pathway from the prescription since it comes in until you dispense it.
Yes,
That's what it means by the workflow. This up to the pharmacist or up to even the pharmacy manager. Okay.
So workflow, it's not regulation. Okay, workflow is the organization of the team.
Exactly, organizing the job.
I see.
By the way, NAPRA, guys, has nothing to do with the pharmacies. Okay, it's only about medications. The pharmacies licensing and accountability and responsibility, and even the organization, the internal organization of the pharmacies, like the Schedule 2, Schedule 3 medication and Schedule 2 medication, it's responsibility of the province. In Quebec here, we have some different, like Plan B. Plan B, in Ontario, for example, you are selling it on the roofs, on the shelves, correct? For the Plan B.
Yes, that's right.
Yes, you can go and pick it up and leave. In Quebec, it's different. It's Schedule 2 in Quebec. So who had decided that the Plan B should be the pharmacist's responsibility? It's the Quebec College of Pharmacists. Okay, so a difference here. There is some discrepancies between NAPRA recommendation and provincial recommendation. Okay.
Okay, thank you.
So NAPRA has nothing to do with the
pharmacies.
yes, with the pre-practice. With pre-practice, yes, nothing to do. It's
I think it is. I think it is NAPRA. It is only regulatory affairs. Put the regulation, put recommendation, and that's it. But the college, it is the executive part, which which see everything inside the pharmacy, which give the notifications, which can control the pharmacist like that. I am right?
Yes, correct. Correct. So Heba is asking again about NAPRA rule. NAPRA rule is only like advisory board. It gives like recommendations. This medication, I think it's safe, so you can for all colleges you can make it like Annex 3, Schedule 3, for example. This medication has many side effects and have to be closely monitored by a physician. So please keep it at Annex 1, Schedule 1, excuse me. Okay, and that's it. And it's only at the end of the day, it's the province or the college role to decide, yes, I will proceed with this medication as Annex 1 or as Annex 2. I gave the example of the Plan P here in Quebec. It's Annex 2. Okay, so it's the pharmacist who has to like make an evaluation with the patient and then decide, I will give you like Plan P or not. Okay, in Ontario, it's different. Any patient can get in the pharmacy and pick up the Plan P and leave. Okay. With the pharmacy regulations, like for any college, it's a responsible body who can decide. Yes, we have to like put the Schedule 3 medications away from other grocery foods or grocery goods that are being sold in the pharmacy. It's here like the work. I don't know what the work, the layout, the pharmacy layout. It's a responsibility of the college as well. It's not NAPRA. Pharmacy regulations and pharmacy licensing, it's the responsibility of the college. NAPRA is only concerned with the recommendation of the scheduling, the drug scheduling. That's it. Nothing more.
Now, let's move on. Okay. Type. Yes, there is no sub regulatory. What is the difference? Tamam. Regional health boards. Hospital administration board. Okay. For your knowledge, the largest share of spending here in health, like all over Canada, is like hospitalization and hospitals. The largest share of insurance spending definitely on drugs. Okay, and this is like a snapshot from which medication takes the most share. Okay, let's have this question. Okay, thanks. Yes, if it come across a question says that distribution of health expenditure in Canada, definitely the hospital take the most important part. Largest, not salary staff. Salary staff is different, Rima. Salary staff is the physicians. Okay. Then it when it comes to expenditure of like insurances and third parties, it's for drugs, definitely. Okay. The special access program. Special access program. This is a very okay, I'm not sure if you guys are familiar with this access program or not. Okay, let's say if a doctor has one of the patients that he tried all the guidelines with him and it didn't work. Okay, and there is like a new medication comes up in US, for example. How we play a role in this kind, what's going to happen here? So what's happening here is the healthcare provider, which is here the GP or the specialist, even going to write down documentation and send it to the government. If the government approve it, then the manufacturer will contact the doctor and he will supply this medication to the doctor office. And after that, after administering by the doctor, administering this new medication, he will write down the efficacy, what happened, and the side effects he came across. So our role as a pharmacist here, either community pharmacist or even like a hospital pharmacist, we have zero role in special access program. So it's definitely between the doctor, the government, and the key player here is the manufacturer. The manufacturer has the right to say, no, I'm not going to supply this medication to you for any purpose. Okay? Is it clear? So regarding the special access program, is it clear? This process is clear? See, we as a pharmacist, we don't have any role here. Okay, so it's either between the doctor, the manufacturer, and the government. Tamam? Yeah. Special access program, drug may only be sent to the practitioner office or inpatient pharmacies. The manufacturer are not permitted to send except to retail pharmacies. So it has to be in the hospital or even the doctor office. Tamam. The cost of this medication is covered by either the patient, the hospital, or even the family, or even like he has like a third party. One of the example for the voluntary professional association and advocacy on the professional levels, the OPA. OPA is like the Ontario Pharmacists Association. National level, the Canadian Pharmacists Association. Practice specific. For example, the hospitals, they have their own association to society. Okay, what the role? The role is advocating, negotiating fees, providing continuing education, publishing. For example, if you wanna subscribe or get a role with like our XTX, you're gonna contact these people, like the Canadian Pharmacists Association. Tamam. Rural and remote pharmacy practice. Rural and remote pharmacy practice and the First Nation. Let me check this one. Could you repeat the cost? Oh, the cost can be covered by either patient can request or never. I don't understand what you mean, Shaima, but however, the cost is covered by either the patient from his pocket, or even he has like a private insurance, or even if it's like can be covered by the hospital if he's an inpatient kind of patient. Okay. Type. What's happening in the rural and remote pharmacy practice? Because Canada geographically is very huge, and there is like low population is scattered all over the country. Okay, so the pharmacist role here is fundamental. Why? Yeah, it's according to his plan. Okay, as the normal drugs. If he's inpatient, we said if it should be covered. If inpatient is like he's outpatient, so it depends on his income. Okay. And again, I didn't understand your question. Can patient request or never? I don't understand this, Shaima. Whoever is requesting is the doctor, not the patient by himself, because the doctor has to fill like a form. Okay, so they give expanded scope kind of privilege to the pharmacists, specifically in Alberta. Why in Alberta specifically? Because they have Alberta is one of the provinces. They have like rural areas and stuff like that. So it has to keep the communities more covered by a healthcare provider like a pharmacist or something like that, to decrease as much as they can, to decrease the referrals and seeing the doctor. Okay, who is concerned more about the patient? CPHA or the college? What do you mean, Rahaf? What do you mean by who is concerned more about the patient? What does it mean? Concerned regarding what? Okay, so if you read, if you open the Ontario College of Pharmacists website, you can definitely see that's their mission is, or their vision, I believe. They work for the patient interest. Okay, so they do this all regulations to make sure that the patient is in good hands, if that's what you're looking for. Okay. Okay, so is that clear, Rahaf? Okay, tamam. Give me 1 second. Let's say, for example, if you're a pharmacist in a very rural area, so you will find that you in this kind of areas you will have like a lot of scope of practice. For example, they will give you prescribing rights, like people in Alberta, for example, can prescribe. Why they do this? They want to minimize the physician referrals because there is not much physicians in this area. That's number one. They want to manage as most patients as they can. They usually go there for like, I used to like serve in an area like in Sudbury, it's northern Ontario, even between Sudbury and Timmins. I'm not sure if you guys are familiar with this one, but people go there like a group, like a medical team group, like for example, like a pharmacist, social worker, and nurse practitioner, doctor, and nurse. So we go there by, let's say, for like a mission for a week or 2 weeks or something, and then we go back. So it happens and because Canada is a very like huge, and we have like we have like people in the north and do that. So to assure that they got the service, we have to make sure everybody has is knowledgeable, and his expanded scope is like good enough or like wide enough to fulfill all the service he can give to this community. Tamam. Yes, it happens, and it's not only because of this to serve only this kind of communities. It happens because if you come across any kind of clinical urgency or emergency, for example, these days, in Ontario just started to rely on pharmacy technicians to inject people with like vaccines. So I assume in the future it's gonna be one of the roles for a pharmacy technician to give vaccines as well. Okay. Yes. First Nation, Inuit, Aboriginal population, and culture competency. Okay, so as okay, let's be frank here. There is a huge difference between the practice here and our practice back home, specifically when it comes to cultural competency or diversity. For example, after you get graduated, some people will specialize in addiction treatment, for example. Some people will specialize in pharmacies that work for or serve like LGBTQ community. So you have to be open towards dealing with these people, specifically when it comes to Inuit or First Nation. First Nations are tribes. They don't go by the laws and legislations as like most for example most Canadians, and they have their own reserves and stuff like that. This areas they live in, they have their own rules. So if you're gonna come across this kind of service you're serving or dealing with this kind of clientele, you have to make sure that you're open to so many, culture competency, or like you have an open-minded way of concluding everybody. No judgmentals, no when it comes to communication specifically. Okay. Why? Because these people is like they don't have health literacy. They're like very primitive people. I saw some of them when I used to serve in Northern Ontario. They literally they don't cook much food. They just eat it from the trees, and they go for hunting. So then they come back to see the doctor for E. coli and very primitive medical diseases like diarrhea and stuff like that. Because their way of living is different from like how we used to live here. Okay, risk factors of to decrease the health literacy is the age. Whenever like you get like older, like your health literacy decrease. Okay, minority like Amish people, for example, these people, Amish people do not believe in oral contraception. So and they work in agriculture. So they're more into the west of Ontario. They live in west of Ontario, like Leamington, Chatham area, and stuff like that. And they're very good in agriculture. So, but they do not believe, for example, they don't believe in oral contraception. So they can literally see like a family made of like a father and mother and like 6 kids or 7 kids. At this point, if you're gonna serve this kind of people, you shouldn't be like forcing or counseling more on like IUDs and Plan Bs and stuff like that. So you have to be aware of whom you're dealing with. Low socioeconomic status, like homeless people, poor health status, low degree of education. Make sure that you use lay language when you're dealing with these people. Okay, so and this is the consequences of low health literacy, like poor health, speaking slowly, clearly, outcomes, increased health cost. When you deal with these people, like make sure that you speak lay language and slowly, don't use like medical jargons and stuff. Visual aids. If you come across, for example, if like a senior guy was like a Chinese senior guy, he cannot like understand much English, for example, so make sure that you provide visual aids, even written, or if you have like one of your a team that speaks the same language, grab him to help you with counseling, for example. Okay, I believe all these kind of things usually come across in our exam, so that's why I put it here. Okay. If you come across, let's say, one guy who doesn't feel like it's complicated to use like the Brio-Lepta or like the Symbicort or any puffer, make sure that you repeat the information back and show you that you can use it. You know what I mean? So all this kind of things that will help you deal or communicate with people. So someone is decided to have a concert here. Off mute, please. Thank you so much. Okay, Shabab, I am done with this. Any question regarding this?
Yes, doctor, quick question.
Yes.
When like if you're doing counseling to patient who doesn't speak English or doesn't understand English, and they
Yes.
have
You have two different. Okay. Complete your question, Faid.
Yeah, and he's come with the caregiver. Your eye contact should be with the caregiver or should be with the patient?
Can you raise your voice, please?
A patient.
I hear if you're counseling an unspeaking English patient.
Yes, and there is a like he is come with a caregiver. Your eye contact.
There's a caregiver, yes.
Your eye contact should be with the caregiver or should be with the patient?
Your eye contact should be with the one who you're talking with.
Okay, so like I don't have to, like my eye contact shouldn't be with the patient?
Your eye contact should be with the guy who are you talking with, to make sure that he's understanding. if I come across you with my father, and you're explaining to me, okay, so, and you're not having I'm the one who speaks English and my father doesn't, and you're not having an eye contact with me, you're having an eye contact with my father. My father is not understanding you anyways, right? So, and you lost contact with the one who understands, right?
Yes.
Yeah. So why you lost contact? So you didn't do anything. You didn't do
because
like,
he's the one, like the designated one. I don't know, like, you know, they're just.
So whoever you speak to, you have an eye contact with him to make sure from his body language that he's understanding, and ask him. So at this point, I would rather have an eye contact with the social worker or the caregiver, and make sure again that he's understanding what's happening. Because when they go home, it's his responsibility to understand the guy who's not to the patient, I mean, who's not speaking English, right?
Yes.
He's insisting he got it here Friday at 90 milligrams.
Give me 1 second.
He said he got it from mom. Said, is there maybe a way that it wasn't put into the system?
Hello? 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 كلموني بالظبط 3 ايام. وهو قبليها اصلا كان ليه ستارت من الدكتور شكلي كان 30 برضه.
يا جازولي راح فين يا شباب؟
هو قال ثواني وجاي.
Do you don't want me to stay?
Yeah, stay.
Can I just go sit?
Yeah, you will.
Okay.
Yes يا باشا. يس بيقول لك بقى هنا ايه حسام بيقول لك with the patient يا فايد. ما تسمعش كلام حسام
عشان انا ماشي
اوكي.
بص انا you have to quit. لازم عندي بس الموضوع لازم اعمله. فبص هسيب لك الميتنج قبل ما تقفل، بس ميك شور ان انت تعمل ستوب للريكوردينج.
stop recording قبل ما امشي you mean or what؟
قبل ما تقفل الروم خالص اعمل ستوب ريكوردينج.
يس
هيجي لك ايميل بعد كده بالريكوردينج ده.
حاضر ماشي انا يا
ماشي يلا بقى نشوفكم على خير. ميعادنا يوم 2 بقى في الأوسكي.
Okay. ماشي طب هبه and I think asking the patient to repeat the information which I said is very important for communication. Yes, asking the patient عشان to make sure ده one of the tricks. تمام. لو انت بتشو him مثلا ازاي يستخدم بافر، خليه يستخدمها قدامك specifically في البافر. ماشي عشان دي حاجه برضو critical. خلاص ماشي يا فايد you're good. سؤالك تجاوب عليه.
تمام يا دكتور. هو confusing بس كلامك هو المنطقي.
بص يا فايد هقول لك خلينا frankly speaking let's use your intuitions. If you're talking with someone, one of the communication styles or the communication point of strength that you make sure that your message is went through properly is eye contact. So by logic, don't confuse yourself. By logic, if you're talking to me, please have an eye contact with me. Simply talking to me and have an eye contact with my father, that has nothing to do with communication, and that's what we say in OSCE. If you're attending with us OSCE, I believe, right? Yes. So use your logic. Don't confuse yourself.
Yes, right.
Okay, because if you're looking to the patient and he doesn't speak your language, so what you're expecting from him? Seriously, he will keep nodding. He will keep nodding his head, and 100% he didn't understand anything.
Yes, I agree with you, because he's the one who has to understand everything. Because
exactly. Yes, so don't confuse it and use your logic. Okay, my friend?
Thank you.
تمام. طيب. Okay, Canadian pharmacy law and jurisprudence. Let us, hopefully we're gonna finish this very soon.
No.
Type. What does it mean by acts? Acts are the laws are created by the parliament. So if I say, let's say, for example, we have like a CDSA act, that means there is a law. Okay, so act means a law. There are 4 federal key acts and regulations. That's Food and Drug Act, CDSA, and NAPRA, and Privacy Act. Okay, the FDA. This one you can read it. We're not gonna spend too much. They are actually categorize the drugs that we have in Canada, diseases and natural health products and stuff like that. Our Schedule F or Part 1 is the one that we're dealing with. That's as per NAPRA. That's a Schedule 1 medication. Okay, so food and prescription drug advertisement standards have all the prescription drugs that are present in the NAPRA. So that our medication that we're dealing with in the pharmacy is under a Schedule F, Part 1. The veterinary is under Schedule F, Part 2. Controlled drugs is G. Okay. So that's the regulations. Sorry?
Doctor, please, the slide of the act again, please. The
slide
of the act. Yeah. Privacy Act. Yes.
Give me a second, Armey.
Okay, sir.
Sorry, Armey, what's your question?
It is okay. No. I don't because I need to know what is the different types of act. That's it. Okay. I want to see it again.
Those are actually the main acts that we related to us as a pharmacist. Okay, Food and Drug Acts that make sure that our medication is under Schedule F, Part 1. That's the prescription medication. Okay, and then they, for example, Part G is like for controlled. That's the CDSA, and we're gonna talk about CDSA later. Okay. This question, the personal use importation requirements for human drugs. We have 2 kinds of drugs here in Canada, either over the counter or behind the counter, or even like a prescription. What are the regulations if you're going, for example, to US, or you're coming from US to Canada, or you're going for a vacation, for example? What are the rules here? The rules here, as per Canada Health Ministry of Health, is you are allowed to take your 90-day supply outside of the country, or bring 90-day supply inside the country. Okay. However, there are some regulations. You have to get this medication in vials, not in the packs. They have your name on it, what is the medication strength and stuff like that. And they always also recommend if you get like a copy from the prescription from the doctor. Okay, so that is required by either prescription pharmacy, or even OTC and behind the counter pharmacy. Okay, so what about if you're either going outside of the country or coming back to the country? Okay, that are the regularities. So what about importation? Let's say you are a pharmacy. For example, in my situation, I'm a pharmacy right on the border between Canada and US, and we have people calling us from US saying, okay, your insulin's here is very cheap, and can you please mail me like insulins and stuff like that, and or even medication and stuff like that. How is this regulated? This is forbidden to be as per FDA Act. Okay, so we are not allowed to import prescriptions to US. Is that clear?
Yes, doctor.
Sorry?
Yes, clear.
Clear. Okay, so here, Noha, what is the difference between a schedule from FDA and the NAPRA? FDA is, we can say, how can I put it? We can say they're dividing the prescriptions or the medications. We don't have only medications here. We have like biologics. We have like, like let's say cyclamate and saccharines, controlled medication, restricted medication, and prescription veterinary. So NAPRA goes more into the part F, Schedule F, and they that's our prescription medication, and they schedule it like Schedule 1, Schedule 2, Schedule 3. That's the difference between. That's how we deal with the medication inside the pharmacy. That's NAPRA job. But the medication that not only medication, it's again, it's maybe vaccines and stuff like that. That's dealt with FDA. Do you know, like, you figured out the difference? I mean, like, FDA is the big umbrella here, not the NAPRA. Okay, type. Okay, so that's what should be done if you're shipping or going away out of the country here, and what you should do. 90-day supplies are allowed. Make sure that you have like so no one can stop you on the customs and take your medication from you, even if you have OTC. It should be for personal use. You shouldn't be like, oh, that's medication for my mom, that's medication for my dad. No. Okay.
Dr. Please, can I ask a question, please? Sorry for interruption. Can I ask a question, please?
For sure.
Now, okay. Now I want to ask for two scenarios.
Yes.
One is traveling from Canada to another country, and I know this. He has the right to take his 90-day supply.
Yes.
Okay, because here in every province, I am a pharmacist. Have the right to give the patient for 3 months in advance in a case of traveling.
Exactly.
Okay. This is our first scenario. The second one, someone came to Canada from, for example, my father came from Egypt to visit me in Canada.
Yes,
now,
he's allowed. You have to send the same thing exactly. 90-day supply with his information on the medication, and if they can ask about a copy of the prescriptions or something, it's allowed, and exactly the same thing. That's with only Armenia. That's not only your medication, Armenia. That's only with over the counter as well. Okay.
This is for both, for the prescribed and over the counter. This is my question.
Yes, for both.
For example, my father came to me and he bring it to him, for example, sildenafil with his own. It is okay for in the airport. Don't
it's okay in the airport as long as he has like a photocopy from the prescription from his doctor back home, and he has the prescriptions or the vials has his name on it. So that's
whatever the quantity, huh?
90-day supply.
90-day supply. Okay.
Yes.
Yes.
Okay, that's the same thing with the natural health product, vitamin, minerals, doesn't matter. Okay, here there is another Emmy question. We are allowed to mail medication between provinces? Yes, you are allowed, no problem. Okay, let's say, for example, you have a prescription medication, and your patient loves to deal with you, and he says, okay, can you please ship it to Vancouver? Yes, you can, no problem. Okay, what if the patient needs more than 90-day supplies? At this point, he can go to if he's moving to another province. So at this point, he will not be eligible to your province. He will be eligible to the other province healthcare program, right? So at this point, he will have to see another doctor at his place. If he's coming from outside of the country to Canada, he has to see a walk-in clinic. If he's going to US for like more, for example, for 44 months, at the other months, the last month, he has to see a walk-in clinic and get his prescription. Okay, so we are only allowed 90 days supply. That's it. What about medical devices? There is no requirement, and no, there are no requirement for medical devices imported for personal use. There is no limitations. Any medical device you want to give, as long as for personal use, you can bring it in, no problem. Mailing medication outside Canada FDA does not allow prescription to be mailed to the US. Okay, so that's forbidden by law. Okay. Traveling with medication without, again, same thing. The maximum of 3 months supply. Okay, allowed to the US. Custom to be transported while traveling to the US. So just to make it clear. Okay, so CDSA. CDSA is one of the most important acts that come across our daily practice, and it's always like one of the acts that they always ask about it during the exam. Okay, here, frankly speaking, if you want to ask my personal like advice, I usually go with the big chart, that the prescribing prescription pharmacy prescription what's that called, summary chart, prescription summary chart. That's what I usually go with. However, here we made like kind of like summarizing to see what's needed, what can be permitted for repeats, or part fills, transfers, record keeping, sales, and loss of self, and what you should do. So there's a difference between narcotic and narcotic preparation. Do you know the 5? Does anyone know the 5 molecules if come across you that's called straight narcotic? Do you know them, Armia? There are 5 molecules.
Sorry, sir. Again?
There are 5 molecules if they are in any compound. That's called
the big 5. Yeah, the big 5.
It's 5 molecules. Yes.
Yes, the big 5. It is. Yeah, I know them. It is one of them. It is the methadone,
Yes.
and the oxycodone,
Exactly.
and the morphine,
Exactly.
and the hydrocodone,
Yes.
and the heroin.
Yes, pentazocine. So heroin,
And
hydrocodone,
yeah, and the pentazocine.
oxycodone, and pentazocine. If this one come across like by itself or even in a compound or whatever, that's called a straight narcotic. Straight narcotic has this criteria: only permitted for written prescription, no verbal, no repeats, no transfers, stuff like that. Okay, part fills are only permitted. What does it mean by for part fills? Part fills means the doctor has to specify the quantity to be dispensed in a specific period of time, from even 1 day up to whatever he wants. Let's say, for example, dispense this patient 1 oxycodone tablet every day. That's a part fill, so this is allowed. Or dispense like 28 tablets of, for example, oxycodone every 30 days. So he specified a specific quantity in a specific amount of time. So that means part fills. Okay.
Sir, please, is the part fill need an interval of time or not?
Mandatory.
Okay, but it needs a right to the whole amount first. For example, I may take 300 tablets, 100 at a time. I am right?
At a time, what time? No, that's not right. At a time, what do you mean by at a time?
At a time means even from every time the patient come to the pharmacy.
What
but
exactly?
Every
what
time it is a limited.
No. Listen to me. What if he come tomorrow?
No. Every time he come after he finished the first 100.
Exactly. What if he come 2 days before?
No,
Exactly.
because we have a total quantity, and
No.
the part fill, it is the partial or it is the portion of the total quantity given according to the prescriber who is prescribed.
Okay, so the wording at a time is not valid here. The wording has to be this way. This may take 300, give 100 every 2 weeks,
Yes.
1 week, 3 weeks. So I have to have a specific date to call it part fills, Armia. At a time is a vague number. You know,
Okay.
we have to
Okay.
get a specific amount in a specific time. If we
Okay.
didn't have this amount, you have two scenarios. You can either dispense the 300 all at once, or return it back to the physician. He can specify exactly what does it mean by at a time. You cannot make it loose, because when it comes to audit, they will go check by dates. Okay, so here the doctor has to write the dates, and they know this. Okay.
Okay.
Okay, my friend. Okay, so who is permitted to prescribe narcotic in Canada? Everything except two: chiropractor and a pharmacist. Okay, doctor, dentist, doctor of veterinary, nurse practitioner, midwives, podiatrists, not a chiropractor. Okay, so chiropractor cannot dispense, cannot write a prescription for narcotics. Actually, chiropractor is not a doctor, by the way. I don't know if you know chiropractor, what he does. Okay. Any question regarding this?
There is another exception, sir. Excuse me.
Yeah, tell me.
The nurse registered, not prescribed. Yes.
She cannot. Yes.
Yes. The nurse practitioner can prescribe narcotics, but the nurse registered cannot prescribe the narcotics.
Yes. So chiropractor, nurse registered, and registered nurse, and the pharmacist. They cannot.
Yes.
Okay. Okay. So this is cannabis. I believe Mohammed discussed cannabis with you guys before, right? I just put it here because it depends on the act. What about optometrist? What do you think, optometrist?
No.
No.
Is the optometrist cannot, the optometrist or the I don't know.
Okay, so there is a difference. Ophthalmologist is the one who's doing, like, let's say, cataract or something like this. Optometrist is the one. Optometrist actually is not. He's the one who's like can fit like a lens for you after you're doing the surgery. Yes.
He isn't a doctor, so he cannot.
He's not a doctor even. Yes, he's not a doctor. Okay. Okay. Okay, so a role of health, what I want to, okay, so you're actually aware of all this because Muhammad discussed the cannabis and stuff like that, right? And the difference between Nabilone and the THC and CBD. I just want to make sure that, yes, Muhammad went through this. Yes, exactly. I just want to go through the Suboxone and the methadone kind of thing. Yes, the MMT. Yes, that's what we need. In 1 second, شباب هشوف I want to make sure that it's record is doing good. تمام. مش الميثادون تريتمنت. طب تعالوا نتكلم على الميثادون تريتمنت كده سريعا. اوكي like fast. والفentanyl patch. طب الميثادون it can be used for both, for one as a painkiller, تمام, and one can be or can be used as a drug addiction. Okay, if it anyone can now, for in the past the doctor has to get the exemption to write methadone. Now no need for this. Any family doctor can write methadone, no problem. Okay, however, it's still recommended as per province that he needs to go through the course. Okay, the course doesn't mean the exemption. Okay, course is for knowledge only. Okay, so okay, so when a patient is admitted to the program, on the beginning he will go slow, start between, like, let's say 20 to 30 milligrams, and then go up by time slowly but surely every week or 2 weeks, the doctor can increase up to 15% from the initial dose, and then every missed dose can be if the patient didn't show up in the pharmacy, you're going to cancel the prescription and then send the fax to inform the doctor that your patient missed this prescription or missed his dose for the day. There is the initiation dose, which is very important. You have to make sure that your patient is consistent in the second, from the 2nd and the 10th, or even the 20th. That's can cause any kind of missed doses. If even a patient missed 1 or 2 doses, even still the patient can get back from the beginning for this program. After the stabilization, at the stabilization phase, let's say after like a month or so, if this patient is stable on, for example, 60 milligrams, so after 3 consecutive days, the patient has to restart the program. In the stabilization phase in Suboxone, after 5 days, the patient has, if he missed 5 consecutive days, the patient has to restart it. Okay, the patient can restart in the beginning, in the initiation, if he missed 1 dose, or in the early stabilization dose, even he missed 1 or 2 doses. Okay, so you have to. Sorry, tell me.
Sorry for interruption. For the methadone, I have confused about missing doses in the initial phase and in the maintenance phase. Okay. I said what I know, and you can correct me if I am wrong, because I want to check my information. First of all, if the patient missed 2 doses in the initial phase, we have to reschedule him. If the patient missed 3 doses or more in the maintenance phase, we have to reschedule him. I am right?
Okay, so if the patient has to, it has to be consecutive, Armia. Okay, what's happening is in the beginning, you're dealing with a human being and he has a habit. So in the beginning or the first, like even 2 weeks or something, this patient will be on methadone and is still injecting from the streets because the habit is still there. Okay, so even if he missed 1 dose, his tolerance is not yet stable. Okay, so the doctor has to restart him. Clear? However, the latest stabilization phase, that means, what's the meaning of stabilization? That means that the patient is now weaned himself off the street drugs and he's only relying on your methadone. Okay, so his receptors and his tolerance is stable for a while. However, after if he missed like 3 consecutive, it has to be consecutive, okay, days, so that tolerance will change. So if you give him this high dose, he will be intoxicated. So that's why we return him back. Okay. For example, there's another example on it. If a patient is on methadone and he went through, for example, an accident or like a surgery, and the doctor prescribed him oxycodone, is it okay to prescribe oxycodone while the patient is on methadone or no? I believe that's a half question. You can.
Oxy what?
Oxycodone, Percocet,
okay.
or Tylenol or 3. Okay, so you can give another opioids with methadone for severe or breakthrough pain. However, make sure when you give this or dispense this, you have to dispense naloxone kit because this patient is under risk of being intoxicated. Okay, too much opioids in his system, right?
Yes, because I see this question, we can give the patient, what I know that is we can give the patient an opioid for a pain while in methadone.
Exactly, you can. Yes, definitely you can. However, when you dispense it, make sure that you offer like an naloxone kit because too much opioids in his system. Okay.
And because methadone have no ceiling.
Exactly. So to put him intoxication. Regarding Suboxone, again, if in the initiation, if you missed 1 or 2 doses, you have the patient will get back to like square one. Okay, but in like latest stabilization phase, he can miss up to, for example, 5 days consecutively. For example, if you have like a patient who's on Suboxone, he's been on it for like 3 months or something, and he's on the maximum dose 24 or even 32, and now he is missing 4 doses, and he comes to the on the 5th day. Still, you can give him. Okay. Okay. What if the patient is traveling? What if the patient is traveling? What do you mean? What if the patient is traveling? If the patient is
yeah, what if the patient, for example, this patient is traveling for a week or so, and
exactly.
How does he get his dose?
Exactly. So at this point, he can contact his clinic, and the clinic will contact you and cancel his prescription for the rest of the week, for example, and give them another prescription. Give the other pharmacy another prescription. Okay, as long as he is observing. This patient come to observe the methadone drink or the Suboxone drink every single day until they get stable. Once they get stable, the doctor get a trust, and then he will give him carry. Okay.
So, sir, if the patient, because I see this question, if the patient will travel, for example, for a month,
exactly.
Because I know that is the care is given as a gift for the patient after an stabilization, but I have allowed to give him only 6 carries.
Yes.
Okay, or 7 carries with a witness of the first day. Okay.
Yes.
So now what about the 3 other weeks? Because he will go in a vacation for a month outside his province.
Okay, so there are 2 scenarios here, Armia, actually. If he going through for a vacation outside within Canada, let's say in Alberta or something, so
Yes.
he can give you a prescription for a week, observe, and 6 carries, and when he go to another pharmacy, okay, his doctor here will fax over whatever pharmacy he wants. That's number 1. Okay, so what if he's going outside of the country, going back for like a month or so to England, for example? And I saw this case. The doctor will actually give him a report that he's on methadone because of the customs, and he gave him actually like a month's supply of carries, if only the doctor trusts him. Okay.
Who give me a month of a carries? Here in Canada?
The doctor give us a prescription of a month carry, okay? And we dispense it to him. How are you going to dispense it? Make sure that you do your documentation properly, and the doctor will do his documentation properly. Please bring your tickets and sign here and stuff, all the stuff you know, okay?
But within Canada? Canada?
Yes, within Canada, give him one week, and then whoever he goes, send him another prescription. Doesn't matter.
Okay.
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 So that's regarding the carries is only it's a doctor job. It's not your job. Okay. So whoever he feels like he can give him a carry for any reason, he will give it. No problem. Okay. Can we split the dose, for example? Yes, so we can split the dose of either methadone or even Suboxone. Okay, so for example, if like someone has high metabolism in his body, like genetically, okay, and he got the dose like early in the morning, and he feel like the withdrawals like at night, he cannot sleep. So the doctor can allow to split the dose, get half of it in the morning in front of the pharmacist, and then the other half take it home. It happens. Okay. What if he vomited unwitnessed? For example, if you are in a pharmacy and you at the pharmacist saw him vomited the dose, what's going to happen? You're going to report it to the doctor, and the doctor will give a new prescription with half the dose. What if he vomited outside of the pharmacy and no one witnessed? He will lose it. He will lose it. No more. Okay, so here the key point you have at the pharmacist, you have to see him miss this dose or vomited. Okay.
Sir, the methadone are not transferable. I am right?
Not transferable, no. 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 Okay, so Rima says here, sorry, I couldn't hear time frame of methadone withdrawal symptom. Okay, so the maximum withdrawal of methadone is three days. And this question is critical. Sometimes it comes in. Okay. Okay, so the maximum. I don't know, Rima, if that's what you are meaning. That's what you mean with your question. The maximum withdrawal symptom of methadone starts with like the peak is 3 days. تمام. Our course said peak 3 to 6 على راسي. Your course على راسي. No problem. Okay, the end of. Oh, just try 30p.
Just type it into the thing then?
Okay, so when it will end? No, it doesn't. No, I saw some people like trying to quit methadone. It depends from 3 weeks up to even like months. So it depends on their metabolism. It depends on their how their body react to it. I know someone was on methadone and he tried to stop the program and he came back after like after 2 months. He still have the shakiness and withdrawals and stuff like that. So it depends, but for sure it's not a 1 week or 2 weeks even kind of thing. Okay, up to 3 weeks, a month, up to sometimes 2 months, 3 months, it happens. Okay, if you open the methadone monograph, you will see this information. Okay. Yes, it can take longer. Exactly, my dear. It can take longer. Yes. Yeah, all the depression may still more than 3 weeks. Yes, yes. All the withdrawal symptoms, all this kind of symptoms, it will last. It depends from one patient to another. Yeah. So I believe there's that question. You said your course said 3 to 6 days, and there is a specific question for this in the exam, and the answer was 3 days. Okay, type. Let's yeah, it will fade. It doesn't mean it's go away. Will fade. It means like it's become mild, but it's still there. Fading doesn't mean it's like go away completely. Fade, it will decrease for sure. The withdrawal maximum is not after like 21 days. It's not gonna be exactly the same like 3 days. Okay. So the maximum peak is like the maximum peak of withdrawal symptoms like 3 days. Okay. I hope I am clear. Type. Fentanyl patch, now fentanyl patch, it can be used. Every patch can be used every 3 days. Outside, sometimes it's used every 2 days. So if you got a prescription every 2 days, we can switch the patch or we can apply another patch. Yes, it happens sometimes in practice. The dose of Suboxone every other day or daily? It's daily. And daily. It's and it's sublingual, by the way. So and you can split it and put it under the tongue, but you cannot chew it. Okay. Okay. Fentanyl patch. Now, if you're gonna dispense fentanyl at the pharmacy, you have the patch to patch program. Whatever you get, let's say you dispense the first prescription, give him 10 patches. After 3 days, he has to bring in the 3 patches and give him like a form or something. He has to stick whatever patches he used, and then he give it back to you as a pharmacist, so you can easily give him back the new prescription for the other months. What if he missed 1 or 2 patches? That's maybe an indication of drug diversion. So you have to inform his doctor. Some doctors says, okay, I know him, I trust him, no problem, give him the other 30 patches. Some doctor says, you know what? You give him 30 and he brought back 28, so give him 28. So it depends. Okay. However, otherwise, if there is any discrepancy in the patches he brings back, you have to inform the doctor. Okay, and that's how it goes. Why they do this patch-to-patch program? Because in the past they didn't care about it, and they thought like now we have like an overdosing crisis because of the fentanyl patches. Okay.
So, doctor, question, please.
Yes.
So what about the flushing the toilet?
What about what? Sorry.
Flushing the patches in the toilet, like when disposing the patches, there's a choices of flushing in the toilet.
Yes. Do you? Okay. Okay. That's a good question. Okay. So how after you they can okay. So it depends on the doctor actually. They can now in the past they used to flush it in the toilet and stuff like that. You know, but now they have to bring it back to the pharmacy. Okay, and it was recommended. If you see the Duragesic, which is the fentanyl brand name monograph, they recommend to flush it that way. Okay, so to stay away from any kind of secondhand user or stuff like that. However, when they bring it back to the pharmacy, what we usually do, or what we have been advised to do, we burn it. You know. So they bring you, like, let's say the used patches and stuff, and then you keep it in a safe place and you burn it. That's what I did before. I don't have this kind of patient, like frequent patient, but I deal with like two of them, and that's what we did. And when we asked the college about it, they said, okay, as long as there's no, you may have to make sure, serious responsibility to make sure there's no secondhand user. Okay.
So back-to-back program is to avoid diversion or to do the right disposing.
The patch programs is mainly to avoid diversion.
Okay.
What happened is the fentanyl patches were used actually to be administered or given to the cancer patient. Those cancer patients, like in the stages, you know what I mean? So they have like their relatives or like whatever, like staying with them, caregivers. So sometimes they steal from them, and you don't know, right? So it's not always the patient has, the accusation. You don't always accuse the patient. Maybe whoever is like beside him or something like that, he has a grandson or something, a granddaughter, like steal from him, stuff like that. It happens. You're dealing with people here, okay? So they said, okay, so now we have to apply this patch to patch, but you as a doctor have to be aware of the situation of your patient, right? If he really like a sneaky guy or something, like, and he has a history of diversion and stuff like that, or is like a senior old lady that lives with her like grandkids and stuff, they're the only people who like take care of them, and like that happens once or like twice, like in a long time. So it differs here, you know what I mean? Fine.
Yes, I see.
Yeah, so it depends on the situation mainly, but mainly they put the patch-to-patch program just to minimize the diversion as much as they can. By the way, it happens still. Yes, it happens still, right? Because we still have like this crisis, right? But it's not like before. And usually they recommend, if you're gonna like dispense fentanyl patch and stuff like that, make sure that you dispense the naloxone. Always counsel on the taking so many like opioids, because they're on fentanyl patch and they having like another opioid, for example, for whatever, like breakthrough or whatever, you know what I mean? So it's like kind of, we can say a combo, this kind of complicated patients. So that's how we deal with. So they try to come up with ideas just to decrease the diversion. Okay.
Okay. Thank you.
Sir, please, I will leave now. Thank you for your efforts, and thank you for our colleagues.
I
will leave now because I have something to do, and I will see you in another scheduled program.
Inshallah. Thank you so much.
Thank you, sir. Goodbye. Bye.
Okay. Here, this is an applies exception in the following. That's what we were talking with FIDE, for example. There are some exceptions here. Well, you can even read it. It's just kind of examples. For example, dispensers apply exceptions when dispensing to a resident in a long-term care home, or person who is confined with correctional facility, or a patient of a hospital in the following circumstance. A correction facility here is like if he's a prisoner, for example. If you're dealing with a prisoner and you have a deal with this prison that you supply all the patches or all the medication for this inmates, you know, at this point in the prisons, mainly they have like doctors, nurses, and stuff like that. So you, at this point, you're not going to apply the fentanyl patch to patch. You will give it to them, okay, and they will administer it there, okay, and then they will collect it and get it back to you, or they have their own, for example, a kind of disposal. They have a deal with like another companies that can dispose their own, you know, residues or stuff like that, you know. So there are some exceptions here as well, right? For example, a prescription has been authorized by a prescriber from outside Ontario, and the prescription is provided by the dispenser. Okay, so at this point, you can dispense it, no problem. But fentanyl patch is one of those prescriptions that's supposed to be directed to a specific pharmacy as well. You know, so same thing like methadone prescription or Suboxone prescription, right? So if, for example, this guy has his prescription in hand and is directed to shoppers in Toronto, and now for some situation he's here in Niagara Falls, what you gonna do? You're not gonna dispense it? No, you're gonna do your job. First of all, you have to verify the prescription, call the doctor, and call the pharmacy and make sure that it's not dispensed already and this is not a forgery, and then we can start from there. You can dispense it because of the situation is happening, right? Okay, Faid?
Yes, tamam, doctor. Shukran.
Okay. So there are some exceptions to the program. You have to be like kind of flexible, and you know what you're dealing with. Okay. This is the counseling on the how to use the fentanyl patch clean area. You know, if you come across the exam, how to counsel on how to apply on the fentanyl patch, here is the steps. Okay. Okay, so this, as per this one, the regular hours, every patch can work for up to 72 hours. However, in practice, we can say some patches, the doctor wants you to dispense every 48 hours. Okay, so it happens between 48 to 72. So provide consumer returns to a licensed dealer. Yeah, here how is destroyed. You have two options. Okay, pharmacist has a choice with respect to the method of destruction. That's why we were talking together. Fine. Post customer returns. Yeah, destroy it locally. You know how to destroy your stuff, like burn it or something like that. You know, or use post customer returns container. If you have a deal, like your pharmacy have a deal with like one of those kind of disposal contracts with like other companies, stuff like that, they will do it. You know, you have to have like a process in your pharmacy to destroy them properly. That's it. Also must be witnessed by a practitioner, pharmacist, pharmacy intern, or technician. Pharmacist carrying out local destruction return must record. Yes, as long as you're gonna destroy narcotics, you have to do your job. Like you have to have a witness, you have to do documentation, stuff like that, right? Okay. Specify the name, the quantity, strengths per unit of each substance in stock, the name, the address of the licensed dealer, if you're dealing with a dealer, for example, the date in which it was sold and provided. Okay. Yes, one of the precursors, one of the main pillars in the CDSA is the precursors, for example, and we have a lot of precursors here in Canada. However, this is the pseudoephedrine. This is the most important one. Okay, it has to be sold in a pseudoephedrine below 3 grams per package, and usually there's like a very popular question on it. If you notice in a pharmacy, if you notice that the sales of the pseudoephedrine recently increased or whatever, what should you do? Put a label, put someone protecting it, putting behind the counter. Always put anything over the counter, put it behind the counter if you feel that there is abused. Okay, always put it behind the counter. Why? So you have a control on its sales. That's number one, and you have the chance to counsel on it. Education. So that's your role, is educating people how to use this kind of stuff. Okay.
Doctor, I have a question regarding this point.
Yes.
There was a question regarding someone came and taking like amount of pseudoephedrine.
I cannot hear you. I cannot hear you, Faid. Sorry again.
So someone just came, like there was a question regarding this point. Someone usually come and buy like a bulky amount. Let's say it's like bulky, like a big amount of pseudoephedrine for someone else, like let's say in US. So what's the like the pharmacist concern? Is it like there will be no counsel on this like product? And like there's a few options, but the question is, what is the most concerned the pharmacist?
The most concern here is a diversion. Okay, so that's what we're concerned about. He gonna misuse.
Sorry, the other choices was worry about the like airport, like examining like procedure.
Okay, okay. Can you write it down so I can see it clearly? If you write it down, I will answer you. Okay, because something wrong in the voice. Okay. Yeah, write it down. Okay, so a technician can witness operate the instruction. A technician is different from assistant. Technician is a license number. He can write his own license as well on the document, so it's allowed, no problem. Okay, and actually, technician can witness even in the hospital too. Okay. Yes, on-site destruction, off-site destruction. We did that here. We finished this. What you're gonna do if you're the records, instruction records, and the name and the quantity, precursor, date, method. 2 qualified witnesses must be on hand during the destruction. 2 qualified here. Anyone has a license or has a liability. Okay, Rana. Anyone has a liability or a license, he can do it. No problem. He can witness. Yes, and NAPRA. ده اللي احنا كنا بنتكلم فيها. That's what we were talking about. That is the voluntary association of province and territory pharmacy regulatory bodies, as well as the Canadian Forces Pharmacy Service. Member organization regulates the practice of the pharmacy and operation of pharmacies in their respective jurisdiction in Canada, and their primary mandate is to protect the public. Okay, so it's a voluntary association, work in parallel with its members. Its members here is the colleges. Okay. What's the question? Okay, most things concern pharmacists about pseudoephedrine when dispense bulk amount. A drug diversion, I believe. If this one of if it's one of the choices, if not, just put in the choices and I want to choose one. The main 7 main competencies that NAPRA set out is patient care, professional collaboration with teamwork, ethical and legal professional responsibility, drug and therapeutic and practice information, communication, drug distribution. Here, schedule 1, 2, and 3. I believe everybody knows what's the difference. Okay, and even schedule U. Okay, schedule U is can be found in any retail outlet. Okay. Bacitracine, I believe bacitracine is one of the main things that they ask about. Mopirocin doesn't need a prescription. Okay. Drug sample. Drug sample, it depends. The drug sample, you can dispense a drug sample, but you can charge the dispensing fees only. Okay, you should not charge the price of the drug. Only charge the dispensing fees. Okay. If it's schedule 1, again, drug sample, difference between schedule 1, 2, and 3. So you have to follow the rules either which schedule it belongs to. Okay. Privacy Act, which is the PEBC. Okay. So PEBC is or Privacy Act. You have to make sure that personal information is protected either electronically. That's what it's named, Personal Information Protection and Electronic Document Acts, and encourage the personal privacy, confidentiality, and access to information, sets out appropriate method of information collection and retention. What does it mean? For example, if you are a pharmacy and you got a phone call from a hospital, okay? Sorry, bacitracine, okay? If you are a pharmacy and you are getting a phone call from the hospital and they tell you, okay, please send us a medication list for the last 6 months. Are you going to send it to fax them or no? So that's a question. If you got a phone call from a dental, okay, that he says, okay, listen, I'll have your patient here, and please send me the prescription, the medication list for that guy. If you have another doctor in the same office says, could you please send me the prescription for this person? So you have to send it to the first one, not the second one. Why? What is the key point here? Does anyone know the difference? What is the key point that make us take the decision to send this kind of confidential information? Dalia or Faid, Hiba, Shaima?
Doctor, I didn't get your answer.
Okay. You didn't get my question.
Sorry, question. Sorry.
No, if you have to, if we have two doctors, two dental doctors in one place, okay, one of them is going to apply a surgery on your patient, and he called you, can you please send me the medication list for this patient? And after like 10 minutes, the other doctor, okay, is not going to provide any care for the patient, and he's asking you for the same thing. However, both are in the same place. Are you going to send it to him or no?
For the surgery one, yes. For the patient interest, I have to do that.
So so you send only information for one of your patient to any other practitioner who gonna provide the care to this patient. If they're not gonna provide any care, so you are not allowed to send his information. Okay, is that clear?
Yes.
Exactly, the surgery dentist only. However, both are doctors. It doesn't matter. Okay, so you're gonna send the information or give out the information for your patient to any kind of or any facility that will provide patient care to him. So that means you shouldn't be giving any information to insurance companies because they're dealing with money, not dealing with any patient care. Is that clear?
Yes, you are clear, but the point is confusing.
Okay, so
because that you mean like not every health practitioner we have to provide, only the health practitioner that provide a service to the patient.
Exactly.
But what about the insurance? The insurance is also calling regarding like processing few payments for the patient, so they have to know about the file.
Okay, that's a good question. Actually, no. If you come across a prescription for a patient and it doesn't go through for any technical issue, so as a pharmacist, you're gonna call the insurance company, and you go at this point you go by the prescription number. You don't tell her, okay, I'm giving him so and so medication and it doesn't go through. It doesn't work like this. If you said so, that's a breach of confidentiality. However, if you talk to the insurance company, tell her the prescription number doesn't go through. Prescription number doesn't mean showing any kind of medication or confidentiality information. Okay. Yes, because they don't give him any care. They're just like talking about money. That's it. Okay.
Okay.
So that's very important to know or differentiate. Let's say, for example, like a secretary from a specialist calls you regarding like information to be transferred to them to give for the specialist to give him the care. So that's still in the circle. So even the secretary, the pharmacy assistant, the pharmacy technician, as long as there is a care will be given as a result of this kind of information disclosed, at this point you can give it. Okay, otherwise you shouldn't be. That's the main issue here in PEPIDA. Okay. In what age of patient can I share the medical information with parents? That's a very good question. Okay, let's give me 1 second, Dalia, here. So there are 10 principles to safeguard the confidentiality. Number 1 is accountability. Okay, responsible party within the organization. Identifying the purpose, why this information is collected. If it's going to be for patient cares will be provided, then give it. If no, so no. Consent should be obtained when appropriate. For example, if a wife asked you that she needs like a med list or something for her partner, so you have to ask her for a consent here. Okay, even verbal consent or over the phone or something like that. However, if this person just discharged from the hospital with like a Percocet prescription, and he gave it to his wife to come and collect it, for example, that's what's called implied consent. So we assume that's a consent and we should give it to her. Okay, because you already have the prescription. Limiting collection, only vital data collected. What does it mean? If a doctor asks you for a three months worth of information, do not give him the whole year. Give him what he's asked for. Okay, accuracy. You have to make sure that the information you're giving is updated and completed. Safeguard appropriate control of information. Don't give anything over email, only faxes, because there's no control on information on email, because that can be breached. Openness, individual access. You have the right to access your own information. If you got a lab work test, the results, you can definitely call them and tell them, I need my results. They will send it to you. Challenging compliance. You have the right to submit corrections. Okay, so back to Dalia question. At what age? Frankly speaking, I don't agree with any ages. Like, that's my personal issue here. But I understand in some other references they said, okay, if they're like below 16, you shouldn't be asking, or below 14, for example. But what if a patient that is 65 and he has Alzheimer's disease, he's schizophrenic, and he has a caregiver? So it's not here it's not for me, for example, it's not by age, it's by the situation. So let's say, for example, if this popular example, a lady or like a parent is coming to ask about the taxes receipts or the medical history for their daughter, which is like 14 years. Okay, does it gonna hurt if you ask her if she's still 14? Does it gonna hurt her? It's not going to hurt her or not going to hurt the situation if you ask her, okay, so your mom is here and she's asking about your medical, should I do it or no? Okay, what if he's like 3 years at this point? Okay, so you can give it because she's the implicit caregiver here. You know what I mean? So it's for me, I don't believe in cutoff point or age, like a specific year, but I believe more in a situation. I'm not sure if this answer is satisfying you or not. Okay, Dalia? In emergency and the patient unconsciousness, should I take a consent of his family? Okay, no. If you're saving a situation and if you're saving the situation and it's on the best interest of the patient, you can definitely disclose the information. For example, if this guy like is overdosing on the street right in front of you, and his mom came into the pharmacy and said, what's happening? I know what's happening, so can you please tell me what should I do? Tell her, you can definitely tell her that, and like he's overdosing and that's Narcan, and let's save the guy. Okay, that's an emergency, you know. Patient unconsciousness as well. Yes, exactly. So, but however, like policemen, if it comes to your pharmacy asking for like an information, as long as there is no court from the judge, court letter from the judge, there is, we shouldn't be releasing any kind of information. Okay. What is the purpose of? Okay, is there a question? What is the purpose of the FIPA are as follows. Those establish regulation for collection, use, and disclosure of personal health information to provide individual with the right to access personal health information about themselves and to correct or amend such information. Okay, provide independent review, resolution, personal health information complaint confidentiality. Pharmacy preserves the confidentiality of information about the individual patient acquired in the course. No particular age of consent, but only by assessing the ability of person to understanding and deciding his own decision. I hope this answered your question, Dalia. Okay. So no particular or no main, but some question exam ask about a situation like that, and the word is the age. Okay. Again, so what they are asking for, what is the main issue here? Do they, for example, so if the question is exactly like your question, and the answers are like 18, 14, 12, 10, I don't think that comes in the exam like this. I don't think so. However, if you come across like a question like a parent comes to your pharmacy asking about the use of oral contraception of his 16 years old daughter, that's a red flag here. Or for example, like one of the most popular cases here, a parent come to your pharmacy that he saw that he got a prescription for Percocet from you guys. Should he tell the pharmacy? Should you tell the parent? Should you call the patient before? So as long as there's like a room here, just use it. You know what I mean? Okay, we are actually okay. So daughter using Plan B. So daughter using Plan B. So that's an issue here. So if I like disclose, that will put her and you in an embarrassing situation. So I would rather tell him not to. Like, I will not tell him this information. I will tell him go back and talk to your doctor. Talk to your daughter about it. Okay. So it's not about the age. It's about the situation. Okay. Okay, we're almost done anyways. So the disclosure, when you can disclose. A disclosure required if it's a child or elderly abuse. Okay, so if you see like an elderly like come to your pharmacy with like his face is like swollen and blue and stuff like that, that's a sign of abuse at this point. Like you have to report this kind of stuff like child or elderly abuse. Reputable communicable disease, a gunshot wound. Let's say, for example, if a wife came to your pharmacy and she said, okay, my husband is asking about this medication, and please, what is that for? And he has like HIV and stuff like that. It's not a bad idea to tell her, okay, you know what, this kind of medication can be used for this kind of medical diseases, and it's always recommended for the partner to have this kind of precaution and stuff like that. Yes, we will have an opportunity to solve this question. We will actually put a lot of the question bank very soon. Okay. Okay, let's say, for example, this happened with me particularly. So I know a patient who came out as a COVID positive, and she didn't stick to the rules and self-isolating, and she keep wandering here and there, and she doesn't care about much, So at this point, I reported her to public health, so because that's a threat to the community. So that's what meant by communicable disease like HIV, like any kind of during the pandemic and stuff like that. Okay, disclosure permitted only when patient give the consent. Okay, substitute decision maker or guardian consent. Let's say a 90 years old guy with Alzheimer, he has like a social worker. Always give all the information to the social worker, as long as there is like another decision maker or her caregiver. Okay, so medical professional with the circle of care, only with the circle of care of the patient at risk of self-harm or harming others. For example, you have a patient comes to your pharmacy and said, you know what, I'm going to kill myself. You have to report this. Okay, cannot leave him like this without like telling anybody, and he will definitely kill himself. Okay, so you're saving the patient. Court orders, for example, as we said, reportable communicable disease like HIV, corona, whatever pandemic, gunshot wounds. Disclosure will not likely be tested on PEBC exam due to variation between provinces. However, you should understand the overall concept of disclosure. That's what we are actually saying. It's not a cut-off point, Dalia. Between like 2 and 3, you have to say. Between 4 and 5, you not. No, it's you have to know the situation, what's happening behind it. Okay. We are finished for today. Okay. I hope this was beneficial. And if you guys, we will actually submit some questions on the platform soon. And if you have any question before I leave, please let me know.
Yes, doctor. Just quick last question.
Yes, please.
Going back to methadone, always there is a choice in the question, saying, let patient go to any doctor and get a prescription. So is it any doctor that's right? Because you're saying the doctors need to be educated about the methadone, like take courses or something.
Yes, in the past there has to be. It shouldn't be this way. In the past, that was actually before May 2018. Now, any GP has the authority to write the methadone, no problem. So let's say, for example, let's give you this scenario. You're for example, on Sunday, and this patient missed his doctor on Saturday or Friday, and now he's gonna restart, and he doesn't want to go to restart because he's gonna be sick and stuff like that. So he can definitely go to a walk-in or go to like another clinic, and he can get it from no problem, as long as the doctor feels comfortable giving it. It's legal for you to dispense it.
Okay.
Yeah, even sometimes some of them they go to the hospital, by the way. So they admit themselves to the psychic ward, and they can take the treatment there.
Okay, thank you so much, doctor.
No problem. If a police came and asked about tablets in your customer car and they need your answer to take action, what to do? Okay. Like what exactly? Like okay, so if I would not say anything as long as I don't have the consent. Yeah, police come, and I don't care about police coming in. They come in every time. If you're like, for example, like working with a methadone patient, you will have phone calls from jail, from the child services, whatever, and bringing the customers to the pharmacy to take their drink with their handcuffs. I saw this so many times. So as I will not say anything, Delia, as long as I don't have a consent. Okay. Okay, guys, I'm not sir. Muhammad. Sir D is very old. Okay. Meshi, is there any other? Okay, let me give you actually a very nice situation happened a couple days ago. I got a patient handcuffed in the police car. Okay, and I have the police came in. The guy came into the pharmacy. He's like, okay, I have your patient X in the car, and I need, please give me his methadone to give it to him. Okay, so at this point, what should you do? What you would do here, Rashmi or Dalia?
Need to be witnessed.
Exactly. So you take the methadone, okay, and go to the car outside and give it to him, and you have to witness by yourself, or let him bring him inside the pharmacy if you cannot leave the pharmacy. But do not give it to the police, and police will give it to him. You know what I mean?
Yes.
Okay. So that's one of the things that usually happened. Okay.
And the time of vomiting the Suboxone methadone, it's 15 minutes, right?
The time of waiting? No.
Of
There is
vomit.
no specific time defined. Listen, let's say for the methadone, because it's liquid, once they drink it, just talk to him. Hi, how are you? Everything is good today. So once he talks and there is nothing to spill out, so that means he drink it, so he can leave. Okay, the Suboxone, you have to make sure it's dissolved completely, so it doesn't matter. It's not 15 minutes. What about 16 minutes? What about 14 minutes?
No, I'm asking about the time to vomit. Like if it came after 30 minutes and said I vomit.
Oh, okay. So regarding the vomiting, it's actually within like 30 minutes. There is no problem. However, here, if you saw the vomit, you have to document it, because the doctor will reimburse him, will give him another half the dose of the vomited one. Okay.
Oh, okay. Oh.
Yes. So from 15 to 30 minutes. Yeah, we can say from 50. If you want to make it 15, it's up to you. Make it 15, no problem. But my issue here is when they document. When they document, you have to document to the doctor as long as you saw it. If you did, if he went outside and you didn't see it, so that means nothing. Okay.
Okay.
Okay. What do you mean there is no screen? Yes, we stopped, Rima. We are already. Yes, I didn't share any more screen. We are good for today, I believe. Sorry, my dear.
It's better to leave, doctor, because we will keep asking.
Oh, really? Okay. I'm sorry. Okay, give me 1 second. I will reshare it again. Okay. You can see it now?
No, I mean, it's better to close the meeting because we will keep asking.
No. Keep asking. Keep asking. والله. Keep asking. Keep asking. I'm happy لأن هو the management is a loose material. You know what I mean by loose material? It's not like therapeutic. Therapeutic, you can, 1 + 1 = 2.
That's right.
But, yeah, the management is like a loose and it's up to the situation. And you can definitely have another opinion different than mine. And actually, the process here is you can be right, I can be right, as long as you have your own documentation and as per the situation, and I have my own documentation and I have another situation. You know what I mean, Fahid? So
Yes.
there is no obsolete truths for the management part. So that's why some people feel like, you know what, it's easy. No, it's not easy. It's tricky, but at the same time, we have to have a guidelines to know what's happening around us. And then at the end, it's your license and it's my license. You're gonna take whatever decision in practice, and you're gonna be liable for it, and same as me, right?
Yeah.
So that's why always good to have the scenarios, what's coming, what happened. I come across this situation, you know what I mean? So it's always good to share information. Okay, for this question, if the parents tool the information only in case of tax is allowed or not. If the parent tool what is the question? Okay, let's say a parent came in and he's asking for he has a wife and 2 kids, for example, okay, and he's asking for taxes receipts, okay. One of them is 2 years and the other one is 14. Okay, so for me, I'm gonna ask a consent about the 14 years old guy. I'm gonna ask a consent for the wife, and the 2 years old, who cares about it? So he's still under his father's taking care of him. So that's my situation. That's what I'm gonna do if this happened to me, and it happens actually. Some people actually, you know what? Over the phone, okay, my wife will come and pick up whatever, just give it to her. So that's okay, that's a consent. You have to document this in the file. So if it happens in the future, we're not gonna talk to him or phone him every time, No, it's only what happens once and that's it. For example, implied consent. Compliant consent, that's the situations that happen. A lady or a guy who came across, who just got discharged from the hospital. He cannot come to your pharmacy because he's sick still or he's in pain. So he just give the prescription to whoever with him in the house. His friend, for example. It happens. So that's implied consent. It's always good to fill it and give it to him. So that's it, right? No need here in this situation just to call him. Okay, so your friend is here. Can I give him his Percocet, for example? He already come to you with a prescription, right? The management is hard because it differs from practicing back home. Any recommendation for poor of us? My recommendation, seriously, Dalia, is to read as much as you can. We have the material here, and answer questions as much as you can. Okay. Thank you, Rima. Thank you, Abisha. Thank you, Doctor. It was a very helpful session. I have an appointment. Okay, you have an appointment and you have to leave. I know. If you need anything, I'm here. Just contact me. تمام. وإن شاء الله we can continue later. Okay. متشكرين يا باشا. ماشي يا شيماء. شكرا يا شباب. Thank you so much. Anything else?
Thank you very much, sir.
Thank you. I am not Sarah.
Thank
My
you.
name is Muhammad Darashmi. You can call me Muhammad. It's fine.
Okay, Muhammad.
Thank
Thanks a
you.
lot.
Thank
Thank
you
you.
so much. Thank you for.
Thank
Thank you, sir. Salam.
Okay.